everyone. My name is Marie Considine. I'm the executive director with NAMI Westchester, and I have a few slides to share with you just to kind of illustrate what we're talking about tonight. So give me a moment to get that up. Here we go. So can everyone see my screen? Yes? Okay, good. Great. So welcome. May is National Mental Health Awareness Month, so thank you for being on this journey with us. NAMI Westchester supports, educates, and advocates for people who live with mental health diagnosis and for their families. Tonight, we're hosting this webinar on Tardive Dyskinesia, and this will be the agenda. I'll just give some words of welcome, and I will introduce our speakers, who will be Dr. Laitman. Has a mind of its own, and Deb Ginder. Then we will have Q&A, some announcements, and thank you and good night by 8 o'clock. So please, as I mentioned, feel free to choose if you want to keep your camera on or off. That's your choice. Please keep yourself muted until the Q&A portion, which I will moderate. And please know that this is being recorded and that it will be shared on our website. So NAMI Westchester, just for those of you who aren't familiar, we're a nonprofit organization. I'm also moderating the waiting room. So excuse the beeps if you hear that while I'm speaking. NAMI is the National Alliance on Mental Illness, and NAMI Westchester is one of 600 affiliates that we're dedicated to improving the quality of life for all individuals and families whose lives are affected by mental illness and co-occurring disorders. Like I mentioned, please, if you wouldn't mind muting yourself, that would be great. NAMI Westchester is here for you. We have a helpline from 9 to 3, Monday through Friday, 914-592-5458, and our website is chock full of information. It was a small group of people who started NAMI, and now we are an alliance of, as I mentioned, 600 local affiliates, 48 state organizations, and there are 23 affiliates here in New York State. So no matter where you move, you'll find a NAMI. These are some of the programs that we offer. We offer support groups for peers and for families. We offer Ending the Silence, which is an educational program in schools to teach young people about mental health and mental wellness, warning signs of mental health conditions, and warning signs of suicide. We participate in a FaithNet program, where we educate leaders of houses of worship so they are familiar with how to help people, because often they are the first point of contact for someone who might be struggling. We do In Our Own Voice presentations in the community and in hospitals to share voices of recovery. We have Family and Friends, which is a 90-minute presentation of our Family to Family, which you see on the bottom, which is an 8-week program that really educates families on how to help their loved one who has a mental health diagnosis. From communicating to putting together crisis plans to all kinds of things, different chapter every week. Looks like my slideshow wants to move right along to our walk, which is our biggest community awareness event of the year. We had it last week, but we are still fundraising through July 4th. It's our biggest fundraiser of the year, and that walk is what keeps all of our programs at no cost at any time. Our helpline's free. All of our programs and services are free. So we do accept donations as a nonprofit. And this park, Ridge Road Park in Hartsdale, is the site of the Westchester Healing Garden, which is a place that has been designated to be a real beautiful sanctuary in nature where you can go if you've lost someone to suicide or know someone who has had some relationship with suicide. It's a really beautiful place to go, relax, be with nature and your thoughts. Call us anytime you want someone to go with. We'll go with you. Tardive Dyskinesia awareness. week is in May, was the week leading up to our walk. So we did some awareness, and we're thankful to Neurocrine and to NAMI National, who are funding this kind of a presentation. So we wanted to let you know a little bit about the diagnosis, and then we will have 2 speakers this evening, as I mentioned. So tardive dyskinesia, or known as TD, is a persistent involuntary movement disorder characterized by uncontrollable, abnormal, and repetitive movements of the face, torso, limbs, and fingers or toes. So please give a warm welcome to our speakers, Rob Laitman and Deb Ginder. I'll just introduce them to you. I'm going to stop sharing, and I'm going to put a spotlight on Dr. Laitman. Dr. Robert Laitman is on the board of directors for the Schizophrenia and Related Disorders Alliance of America and is a former board member of NAMI Westchester. Dr. Laitman, Louis Opler, and Dr. Laitman's wife and son, Anne and Daniel Laitman, are authors of the book Meaningful Recovery from Schizophrenia and Serious Mental Illness with Clozapine. His wife, Anne, is also an internist who uses an optimal clozapine approach to treat schizophrenia. After their son, Daniel, received a diagnosis of schizophrenia in 2006, Dr. Laitman and his wife started Team Daniel, a 501c3 nonprofit to advocate for and support people living with mental illness. Dr. Laitman and his wife, Anne, are great supporters of NAMI Westchester, great collaborators in the community, and we're happy to have him with us today. And I will hand off to Dr. Laitman, and then I'll bring it back and introduce Deb. So
very good. If you get my slides up.
Sure, I'd be happy to.
All right. And hopefully I know where the control is here. I think, let's see. Okay, I got it. Yep, perfect. Slideshow. Should go right there, yeah. Ah, there we go. Perfect. All right, good. All right, so thank you for having me. Tardive is certainly not my area of expertise, but I have treated it, and Maria approached me right when I was going for my father's funeral. And so I said yes. So I figured I would learn along with everyone else. So I basically want to tell you again what Tardive is. I want to put it into the context of where I think really we should be using our antipsychotics, which is in psychotic spectrum disorders. And that's a problem with Tardive, and why I think we're seeing so much of it is we're seeing these antipsychotics used really a lot off-label, and I don't think correctly. And then I'm going to tell you what the best approach is to Tardive, and that is really prevention. But then I'm also going to talk to you about a little of the neurobiology and how to treat it. So let's see if the slides move. Okay, that's slow. Was that you or me? All right, so again, it's an uncontrolled movement disorder. People do not have any ability to take, voluntary control over this. And it mostly involves the face, the mouth, that's the oral buccal stuff. Boy, it's not moving, Marie.
I can do it for you if you'd like.
Yeah, if you could. Next slide.
Sure.
Thank you. And again, these are irregular, they're almost dance-like movements, they're repetitive, and they can be very disabling. They come in the setting of being on neuroleptic drugs, and people are on these drugs for months and months, and that's when it's developed. Tardive means late. So, and dyskinesia is reflective, it means the movement. Next slide, please. And again, what does it look like? You'll recognize it if you see it. They make odd faces, they stick their tongue out, they pout, they smack, though some people will grunt, people will play the piano as it is, and they have no control over this. They'll have jerking movements of their legs, they'll twist their neck. It can really be very bothersome and disabling. Next slide. Whoops, there you go. And again, as I said, head and face, neck and trunk, upper and lower extremities. Next slide. Again, what is the cause? The cause is dopamine 2 blockade, and they are antipsychotics such as Haldol, fluphenazine, Risperdal, the first generation. The big hope of the second generation was the movement disorders would be much less prominent. As it's turned out, there is a reduction, but it is not as dramatic as we would have hoped. Metoclopramide is a drug used usually for nausea and vomiting, often with diabetes. It is much less common. However, there's a prevalence because we use so much metoclopramide. But again, in our population, the way we use it, as long as you don't have diabetic, what's called gastroparesis, where they use very high doses, Tardive is uncommon. Next slide. Okay, the risk factors, and this is really important. It's, again, older age, and again, first generation more than second, and it's the cumulative dose and the higher dose. So the longer you're on it, the more likely this is going to happen. And again, with the more potent dopamine 2 blockades, other things that can make it worse certainly are pre-existing mood disorders, alcohol, prior ECT, and substance abuse, not surprisingly. Next slide. So I want to talk about where we should be using these antipsychotics. We should be using them in psychotic spectrum disorders, and I want to define that for you. These are complex genetic disorders that are heterogeneous and are often neurodevelopmental and not properly treated neurodegenerative. This slide's a Manhattan plot of not all the genes, but the more recognized genes. And if you can see, one gene stands out more than all the others. And you're going to hear this name a lot. It's for CIS4A. It's a gene that overexpresses something called complement. And what happens is your immune cells in your brain end up causing what's called overpruning of your brain. You lose gray matter. There's only one drug that affects that overpruning, that dampens down the microglia, and that's clozapine. First mentioned. Next slide. Now, psychosis, people always think about the delusions, the hallucinations, the disorganized speech, and that truly is dopamine dysregulation. But that's only one part of the psychotic spectrum illness. So that's the psychiatric teaching, going after D2 inhibition. The problem with that is the negative symptoms, executive symptoms, and even the mood can sometimes worsen as you block dopamine 2. In addition, comorbid substance abuse is not really treated effectively with straight dopamine 2 blockade. Again, what drug affects all 5 of these domains? Clozapine. Next slide. So here's the onset of psychosis. Next slide. And it really is dopamine dysregulation. When you see the real onset, what brings people to the attention of a psychiatrist. Because, next slide, please. So what you need is, and this is the general approach. So when you have this dopamine dysregulation and they're wildly out of control and their mood is dysregulated and they're showing positive symptoms, again, hallucinations, delusions, abnormal movements even, they need to block dopamine 2. This is the teaching. Again, the only drug that seems to work in this setting that doesn't block D2 is clozapine. So that's what we have to get, 68%. You go a little too high, and then you're going to have over blockade early on, and you're going to see movement disorders early. Next slide. So this is just the neurobiology of psychosis. Often, these kids will present with what we call the negative symptoms. You won't often go to medical attention until you get the first episode where they're really showing those positive symptoms. And then that's where people start antipsychotics. Often what happens with these antipsychotics, and if you guys have been part of this community long enough, you'll know kids will discontinue it or they'll just stop working. And with that, you'll get a relapse. That's the typical course, unfortunately, with a lot of these D2 blockade. And what happens with that, as you have relapse after relapse, there are problems. And the next slide, please. And you lose progressive gray matter. Every time you have another episode, because the dopamine itself, the excess, is inflammatory. And just like the overpruning that I was talking about, that accelerates that entire process. So you lose gray matter. Next slide, please. Ultimately, why you need to stay on an antipsychotic if you have psychosis is the survival is not good. Almost 50%. This is the best longitudinal study that we have in the world. We have over 62,000 patients followed for over 20 years. 46% were dead if they're not treated with an antipsychotic. 26% with any other antipsychotic but clozapine, and clozapine only 16%. So onward. Next slide. Let's get back to Tardive. So you can see there is a rationale to keep people on an antipsychotic, and they need to stay on it longer. But what's happened in the United States is we're using it a lot of times off-label, and that's led to the prescriptions going from 15 million to 66 million. Next slide. And with that, we get a lot of Tardive, and the risk goes up each year. 5 years of an antipsychotic. 32%, 49%, and it basically goes up over around 70% at 25 years. And that is with all other antipsychotics except for clozapine. Next slide. So, too many prescriptions written for antipsychotics, D2 blockers. We tend to give it in the elderly where it's a higher risk and their exposure is even worse because they develop it faster than people that are younger. And it's the cumulative effect. Often when you're on another antipsychotic, you need anticholinergics to control the acute movement. And that seems to make it worse as well. And again, too many people being treated with antipsychotics that shouldn't be. Next slide, please. Again, risk factors: age over 50, mood disorder, substance abuse. Always makes everything worse. And then, again, it's a treatment. The more potent the agent, the longer you're on it, the greater the likelihood of getting tardive dyskinesia. Next slide. Again, tardive, it's late. It's after months and months of treatment. If you have something early on that's a movement disorder, a dystonia is where the muscles contract vigorously, or akathisia, which is the motor restlessness. Those are acute things that happen early on. Neuroleptic malignant syndrome is a horrible syndrome. We'll talk about that later. But tardive means late. Next slide. And again, it's important to distinguish what's the difference. Tardive is contraction. The muscle, there's too much dopamine being expressed, and we'll get into the pathophysiology. So there are too much movements, whereas Parkinsonianism is shuffling, slow gait, and a decrease in movement, decrease arm swing, freezing. People with tardive are always moving. Next slide. Again, key questions: acute or delayed? Akathisia, again, motor restlessness, or is it stereotype, writhing all the time? And again, does it get better when you decrease the antipsychotic? If that's the case, it's most likely Parkinson's. If it gets worse when you decrease it, it's more consistent with tardive. Next slide. And again, what complicates the diagnosis? It can be insidious. And what I mean by psychosocial is that, again, stress, since this is dopamine dysregulation, the more dopamine going into the system, the worse the tardive. So someone's relaxed, they come to the office, they have a good relationship, you don't see it. And so it can really present subtly over a long period of time. And the comorbidities can be problematic, especially with substance abuse being the big problem. And finally, the assessment tools, something called the AIMS, and I'll show you a slide. They can be tough to use, and it really requires some expertise. Next slide. And again, it's a standard format. It takes time. You have to be good at being a rater. I'm going to talk to you about a better way of doing this a little later. Next slide, please. Again, So let's review. They look a little similar, but they're associated with antipsychotics. But clinical tardive is very clinically distinct. Again, repetitive, purposeless. Again, dance-like, choreiform, repetitive, and jerky. Again, 3 months of antipsychotics. It can look like Huntington's chorea. It can look like a little bit like Wilson's disease. Believe it or not, autism, I've seen repetitive motion, but it's really distinct. And as you do this more and more and you see more and more patients, it's not a tough diagnosis. Next slide. Yep, good. So is there, okay, is there barriers that contribute to the treatment of this? Absolutely. First of all, we didn't think we had great treatments for it. Second of all, we didn't think that it was that common. And people, we thought were unaware of it. This is just a general nihilism with the approach to taking care of people, unfortunately, with psychotic disorders. And all those things are not true. Next slide, please. It really does bother people. 75% are very aware of this, feel it's stigmatizing, absolutely affects their self-esteem, and makes their quality of life much worse. Next slide. And on top of that, it can be disabling. It can lead to falls, with gait instability. People can aspirate because they have trouble with the oral musculature, and eating and breathing can be affected. So these are really diseases. This is a disease or an illness that needs to be taken care of. Next slide. Again, too much nihilism, something we see often in our community. These movements really affect you. Next slide. Okay, this is the fun part. This is neurobiology. I like this part. So again, antipsychotics, they work, unfortunately, all over your body. So you want them in the mesolimbic, the amygdala, calming things down, decreasing dopamine. The problem is they also work in the substantia nigra, the area of the brain that is responsible, the nigrostriatal pathway, for movement. Next slide, please. And so what happens there is you see drug effect. Next slide. So this is the normal healthy striatum. You initiated an antipsychotic. Next slide. So that was nice movement there. You saw that. And, oh, whoa, you went too fast. Go back. Go back. You missed. There we go. So you see very little movement because we have, and that's Parkinsonism. See, they're barely moving. So they barely had the dopamine being transmitted in the postsynaptic neuron. Next slide. Too quick for me, Marie. Again, striatum with antipsychotics. Next slide. These are just fun slides. Okay, that's with chronic D2 blockade. Watch what happens. Next slide. TD increases dopamine signaling. Next slide. As you can see, there's more of these postsynaptic receptors. And what happens, even though you're blocking with your D2 agent here, now there's more receptors open for business. Next slide. And dopamine gets released, and boom, you have movement, an uncontrollable movement. Next slide. Whoops, too fast. Go back. There we go. Next slide. There we go. Perfect. All right. Oh, you skipped. That is what. All right. So antipsychotic dose. Think about it again. So doesn't it make sense? TD will improve if you increase the antipsychotic dose, because again, you're blocking more of the receptors. But Parkinsonian will get worse. Same thing. You decrease the antipsychotic, you're actually opening up more dopamine receptors, so the movement gets worse. Parkinsonian gets better if you decrease. Next slide. All right. So this is VMAT2. This is vesicular monoamine transporter 2. Say that 5 times fast. Basically, it's an enzyme that allows you to take your dopamine from your presynaptic terminal, put it into a vesicle. That vesicle then goes to the presynaptic membrane, is released into the postsynaptic or into the synapse, and then goes across and binds to your postsynaptic receptors. So the way these things work is they just don't allow as much dopamine into the vesicle. So you're getting less dopamine across, and that helps with the dysregulation or here, next slide. There we go. So it reduces, again, the transmission of the signal, and that mitigates the disease process. It's not curing anything, but it is absolutely helping the symptoms. Next slide. So TD may occur with long-term antipsychotic use. It's dopamine 2 receptor upregulation, what we call supersensitivity. Anticholinergics will worsen this as well. And VMAT2 lead to, again, decreased dopamine and then decreased firing. And this is a way of treating the TD. And it does work. Next slide. So what are the best practices? So what we recommend is, first of all, you want to observe, because what's the best way to treat TD? Never to have it. So the first inkling is you should be considering, next slide, please. All right, and this is what it looks like when it's already very established. Next slide. Okay, so this is the simple and easy way of screening, something called MIND. And it's movement. Do you have it? Is it impacting you? Do other people notice it? And does it affect your daily activity? Any of that being true, that's when you have to address the antipsychotic that you're on. Next slide, please. Again, ask other questions. Twitchy, shaky, jerky, teeth grinding. Again, the oral stuff, that's so characteristic of tardive. And it's interesting because that's where a lot of the dopamine dysregulation is in the striatum. It's located right there. Next slide. So, again, mouth, tongue, arms, legs. It could be lifelong and irreversible. You got to recognize it early. You have to discontinue the offending drug. And that's where, and we're going to go through these requirements, you want to switch to clozapine first. Okay, next slide. And this is a summary of the treatments for tardive dyskinesia. They've tried a lot of things. The only things that there really is excellent data for is switching to clozapine and using the VMAT2s. Next slide, please. And these are the Maudsley. This is our friends in King's College in London, and also APA. They say clozapine or quidapine. We say just clozapine. Next slide, please. Why I say clozapine is because it works much better than quidapine, one, and it is even causes less of a movement disorder. It is the one's antipsychotic that really, dopamine itself binds more avidly to D2 than does clozapine. But again, it's also more effective. So when you're switching, the problem is when you switch to quidapine, you'll often see a decline in the overall status in people that are on antipsychotics, whereas with clozapine, you'll often see improvements. Next slide. And the other thing is, people recognize that, and people stay on clozapine, over 95%. It's better, and this is, again, our Finnish friends. And one of the worst drugs is, unfortunately, quidapine. So use clozapine in this setting when you need it. Next slide. Oh, there you go. So again, this is a Delphi. A Delphi panel is just a panel of experts. Again, review, consider modifying the antipsychotic, in other words, clozapine. Get rid of your anticholinergic, and absolutely consider a VMAT2. But do it one step at a time. Next slide, please. Again, whoa, okay. There we go. So how do we treat it? Again, if it's a very local, and you sometimes see this, where you get just a dystonia, you can treat that locally with Botox. And again, switch to clozapine, as I said, but then you have these three VMAT2s. And the latest generation are the deutetrabenazine, the valbenazine, and the first and original one was tetrabenazine. Next slide, please. Whoa, where are you going? There you go. So this is just an algorithm. Basically what it shows, it's really hard to see, is assess, do they need it? They still need it. Get them off the old other antipsychotic, switch to clozapine, still not good, then start a VMAT2. Next slide. Got it there, Marie? There you go. All right. So again, what's the evidence for clozapine? You know, I'm a big clozapine guy, but there is tremendous evidence for this. Again, patients switch to clozapine, actually with moderate to severe TD, have shown the most dramatic improvement. Mild TD switching rarely worsens it, but sometimes if it's just mild, you're going to need the VMAT2s as well. There's systemic DAT review also supports switching to clozapine to reduce TD risk. Again, what's the best treatment of TD? Never to really significantly have it. Next slide. Now, valbenazine actually is the VMAT2 that I tend to use. In fact, it's the only one I've been using, and there's several reasons. Initially, it was the only once a day. Now there is, the tetrabenazine does come in an extended release formulation. But what's also kind of neat about valbenazine is it only has one metabolite, so there's less interactions with the other drugs. And also you can use it with hepatic insufficiency and with some of the other drugs that we commonly will use. So that's my drug of choice. It's easy. It's once a day. The titration is easy. But the others, in our day and age, you take what you can get from the drug company, tetrabenazine are reasonable drugs. They're just more difficult to use, and you have to be a little more careful. Next slide. So again, whoa, there we go. Summary, we're done. Tardive, medication-induced hyperkinetic disorder. Again, it's D2 blockade. Next slide. Older age, duration of exposure, more potent D2, the worst. And again, this is really important. First generation antipsychotics, 5 to 6% overall per year, 10 to 25% overall in older adults. But second generation antipsychotics, the risk is still 4% overall. So initially we thought it was going to be much better than that, but it turns out not. And again, the clinical features we've gone over, the onset could be insidious, and you really have to be careful and, make the switch. Next slide. Screening is everything. You have to be aware. Again, use your D2 blockers where it's appropriate. Try not to use it when you don't have to. And again, with psychosis, we need to treat with an antipsychotic. So I'm a big proponent of early switching to clozapine since movement disorders is a big problem. Although the diagnosis is usually straightforward, you can get confused. But next slide, please. And we're almost done. Prognosis. So initially, people with denialism thought it was irreversible. So they let it go, they let it go, let it go. And 95% of people never got better. Again, we didn't have the VMAT2s at that time. Right now, we're seeing remission rates up to 50 to 90%. It depends how severe the illness is and how you intervene. And again, there's treatment. So next slide. Again, reevaluate the use of anticholinergic med and the other antipsychotic, make the switch. Don't be afraid of using the VMAT2 inhibitors, but screen, pay attention. And that's it. Done.
All right. Now, did everybody get that? There's going to be a test.
That was a lot of information. Sorry.
That was a lot of information. Right. So everybody breathe, deep breaths. Have a little, I have iced tea, have your water, whatever you have, take a deep breath. And we are going to move right along. And we're going to introduce Deb. Hang on one sec. Let me just highlight Deb. There we go. Hi, Deb.
Hi.
Okay, so everybody, this is Deb Ginder. Deb is a lifelong resident of Lebanon County, Pennsylvania. From 2001 to 2014, Deb taught English language learners at the elementary school level. And since that time to the present, she tutors and assists adult English language learners. Deb lives with a mental health diagnosis and through prescribed medication developed tardive dyskinesia in March of 2022. Deb has become a strong advocate, participating in educational and lobbying efforts on behalf of herself and others living with TD. Deb has served as a volunteer spokesperson at the 2023 No TD Congressional Fly-In, at which people living with TD and their care partners share stories with congressional elected officials and their staffs about how TD has impacted their lives. So Deb, welcome to New York, and we are happy to have you and welcome
Thank
you
you.
to share your story with us. So thank
Do you
you.
want me to talk fast or slow?
I want you to share your story with us, so wherever
Okay.
you're comfortable. Thank
All
you.
right. Thank you for letting me share my story. I'm going to look like I'm reading a little bit because I'm nervous. I want to say first a few things before I start my story. The first thing I want to say is when people ask me, what's tardive dyskinesia? The first thing I say is something like, you don't want to have it. It's also very emotional for me as I talk about it. So if I get teary, that's why. My TD presents itself in my mouth and in my feet. Maybe you were looking at me before I was talking and you could see the mouth movements a lot. When I'm talking, you're not going to see it as much. As the doctor said, the more stress you have, the more your mouth will move. So hence, I was really moving my mouth earlier. Another disclaimer before I tell my story is that it's hard for me when people judge my TD, especially physicians. The worst thing a person can say to me is, oh, I don't notice anything, or it seems totally under control. It would be more helpful if people would say, that must be very frustrating for you, or I wish you didn't have this. So here's my story. I was diagnosed back in March of 2022. My causation drug was Abilify. I was put on that 5 years prior to help with depression and insomnia, which I've had since I was a teenager on and off. I am not psychotic, but was given Abilify not knowing it was an antipsychotic medication, nor did I know there was a side effect as of TD. I started on a low dose, and my psychiatrist kept increasing it to the highest dose, which, as you heard the doctor say, it's more you're more prone to have it if you're on a higher dose and a longer period of time. As I went along, I was still having difficulty with depression and insomnia. They decided to take me off the Abilify rather quickly and put me on Seroquel. That was when I started having the movements. The doctors quickly stopped the Seroquel, but it was too late. They decided that the Seroquel did not cause the TD, but coming off Abilify after being it on so long, coming off it too quickly also contributed to the TD. As I learned later, that you should come off the antipsychotics very slowly. That being said, the first drug that was tried for me was Austedo. These drugs are very expensive and you have to fight with the insurance companies to get them. So that took a lot of work through my health system, the nurses. Finally, I did get it through the manufacturer. So a few weeks in, and my psychiatrist was actually the one prescribing it at this point, my body started to tilt to the left side. He said, oh, we don't know what that is. That could be the Austedo. So he said, stop the Austedo and see a neurologist. So I called neurologist in the same health system. Oh, we can see you in March, which is like 9 months. And I was like, I can't live like this for 9 months. So I got in to see another neurologist. This was like July, and then I got in, I think in September. During that time, and yes, as the doctor said, it really does affect your life. It was hard for me to eat. I got ulcers in my mouth from my mouth moving so much. In August, I lost 5 pounds because I couldn't eat. I had to see a nutritionist who put me on a high calorie diet, had trouble getting food out of my mouth, swallowing my food. She sent me to a speech therapist who helps strengthen your muscles in here when you swallow. She had me do exercises at home. I would see her about every 2 weeks. She started me on a soft diet, would watch me eat. Another 2 weeks, come back. She would increase the textures of the food and just kept increasing them until she would see me eating better, watch me chew the whole thing. That being said, that did get better, but still not able to clear my mouth well. I'll get back to that then, because that's even to this day. Finally got in to see that number one neurologist. He said, yes, you have tardive dyskinesia. The body tilt is tardive dystonia, which is also, I guess, a part of tardive dyskinesia. Went back on the Austedo, titrated up over a few months, full dose, absolutely no improvement at all, but it caused a side effect of severe depression. That December, I went inpatient, psychiatric hospital. They did a slow taper off of the Austedo. At that time, I developed another symptom, which was severe ear and jaw pain. I took Tylenol and Advil round the clock. For weeks I had it, and of course that contributed yet to more trouble eating. After I got out of the hospital, I think it was that January, they decided to try me on Ingrezza. Again, very expensive. Fought to try and get the medication. Finally got a grant to help pay for the copay. That dosing was once a day. Start at 40 milligrams, then go to 60, then go to 80. I found that the 80 milligram dosing was too sedating, so my neurologist bumped me back to 60 milligrams. Then we got to March, 1 year in, and I finally got to see the neurologist in my health system. He says, stay on 60 milligrams, but go off some of the other medications, my other psychiatric medications that can make my mouth dry. So here I am, like what do I treat? I have depression, I have anxiety, I have insomnia, I have TD. So he's saying, get off of this and this that help your depression and insomnia. It's like, what a great choice here. But I had to go for the TD because that's what was really bothering me the most. So it was a lot of tears of not knowing what to do. And hello, I want to sleep too, but I want the mouth movements to stop. That time again, back the ear and jaw pain came back as well. It would come back, go away, come back, go away. I've heard others that have the same. At that point, I still wasn't getting much relief, and my neurologist thought, okay, let's stop the 60 milligrams. Let's just stop the Ingrezza. And I said, well, let's wait a minute. Let's see if we can do 80 milligrams again. Let's see if I can tolerate it enough that I can get some relief, give it a last chance. And I did. I don't remember if I got sleepy or not. But it would help me. I took it at night and would help me till about 1, 2 o'clock in the afternoon. It would be like I got total relief. And then it went boom, it came back. My mouth, my feet were moving all the time. So then my neurologist decided to do a split dose, which is very unconventional dosing, atypical, 40 milligrams at night, 40 milligrams in the morning. Of course, that was 60 pills a month instead of 30 pills a month. So again, we had to fight like crazy with the insurance company to get that approved, but we did. Finally, seeing some improvement all day long, but milder. So I didn't, and to this day, I don't have total relief, except at night I don't notice it. When I close my eyes also, it will stop. So finally seeing some improvement all day long. He also added, the neurologist also tried adding another medication on to see if it could help me even further. But here we go again, another medication. It made me so extremely sleepy. I could hardly drive and I was slurring my speech. It was awful. So we ended with that. Took me off of that. I had been taking notes this whole time, and about October of 2023, I had some significant stressful things happening in my life. And I just, like I said, I kind of stopped taking notes. The TD kind of took a back seat. It's been there with me till just a few months ago. My stressors started to get better, and it has calmed down a bit again. But during that stressful 6 months, it was just really bad again. But like I said, now it has calmed down. So some final points, try and be quick here. Since I started with this, I know the doctor mentioned how much it affects your life. I did not want to go out to eat. The only way I would go out to eat was if I could get soup. And the problem with soup, I'm also lactose intolerant. So, okay, we have to get broth-based soup wherever we go. And my husband was not thrilled about not being able to go anywhere. Because if I did go out to eat, I may not have said this, every single time I eat, and to this day, I rinse my mouth with salt water and floss my teeth because I cannot get food cleared out of my mouth. Eventually, when we went to the fly-in at Washington, D.C., that was a year later, the others with TD said, Deb, it's okay for what you eat. It's okay to go to the restroom and do what you have to do with your mouth. So it's hard to eat out with people I don't want to say I don't know, but who are not very close to me because of my problems. And I'm not just saying because of people watching me, it's the whole swallowing thing is just difficult. Recently went back to my nutritionist again, and she's once again recommending speech for me as I'm having more trouble swallowing pills. I have to get some of the pills in oral disintegrating form. She's concerned about choking again. Not quite sure why this is getting worse again, but yeah. The body tilt also, I mean, you can see me tilt a little bit, but I was really tilting before the Ingrezza. The Ingrezza has really helped with that. And that being said, I think that's about all I have to say is I want to say that for me, I don't have much hope of recovery. I just feel like it's a management of symptoms for however long it may go, may not stop, like the doctor said. And that's my story.
We'll take questions. There is one comment. You were probably never offered clozapine,
No,
correct?
no.
Because we don't use it in the United States. This is just, this is the United States. This is my life's mission is to. So the primary problem remains, if you remember the neurobiology, there's still too many D2 receptors there. And so the problem is still there. You're getting less dopamine going to there, but you still have. So the way around getting past the upregulation is to, if and especially if you're not sleeping, just very low doses of clozapine may give you relief. It also may get, and this is knock on wood, and I hope this happens. There's a lot of reservation about using the clozapine, but the FDA is starting to move, and we're going to be having some conversations with them. And the problem is that people have to do blood work right now. That's mandatory, and that stops a lot of psychiatrists from ever considering clozapine.
Yes.
That may be done by the end of this year. And I'm only, this is pure hearsay, but I've hearsay from multiple people, and I'm actually pretty involved in these conversations
I
with the
think I
FDA.
was,
So,
I think I was offered that, but I was told I had to get blood work
right.
once a week,
And
and I was told that it was not a good option. So yeah.
right, but that's how it's presented. Yes, as I said, it's, if you need, and this is one of my, this is why we have so much TD, because we're using these other agents, we're using them indiscriminately, and people, have been sold a bill of goods, and it's a real problem. And we're the only country, we're dead last in the world in our approach in terms of using antipsychotics, in terms of, the fearfulness, but, that might be changing. So again, especially if the blood work requirement goes away, you might want to reconsider.
Thank
Because
you.
it may be a way out.
For sharing that. Rob, I appreciate your scientific description and you've helped us understand it better. And Deb, you've taken what Dr. Laitman shared a bit further and made it into real life. And I empathize with you with all you've been through. It sounds like you're getting some relief, so that's great. And I'm happy to hear that. It sounds like it's something that is very difficult to live with. So we do have a few minutes left, and I'd like to turn to the audience. Thank you for tuning in with us tonight. I do want to let people ask a question or two, whatever we have time for. So it looks like Lindsay has a question. Lindsay, if you'd like to unmute, you can ask yourself.
Yes, thank you so much, Doctor, for your presentation, and Ms. Greiner for sharing your story with me. I'm sorry that you are suffering with these symptoms. It's very difficult to hear. I did have a question for the doctor. When you said that we see more of the symptoms when it comes to off-label, is that meaning like the generic medication?
No. So, antipsychotics the indication was for treating for, like the name, psychosis. But, there's been some studies and there's some literature that maybe it's helpful for depression, maybe it's helpful for anxiety, maybe it's helpful for post-traumatic stress. The studies are not great. They're suggestive. And, the FDA has given them the go-ahead to do that. That's what I mean by off-label. So there's settings we're using this unfortunately, like candy, because people don't realize that if you, use these drugs, as I'm so sorry, Deb, that they're especially in people that start postmenopausal.
Doctor, is it possible to develop these symptoms not initially, but possibly, 6 or 2 years down the line?
That's exactly, well, that's what tardive means. Again, late.
Okay.
That's absolutely classic. In fact, part of the definition, if you're going to go to the DSM, is 3 months of antipsychotic treatment. So people have to look at benefit and risks a little better.
Are there any studies in regards to adolescents taking these types of
adolescents,
medication?
again, younger, the incidence is lower.
Okay.
If you need an antipsychotic, use it. My whole approach is to use an antipsychotic that does not cause tardive dyskinesia. That's
Yes.
my strong belief, and that's using clozapine. Clozapine, again,
Yes, we started
that's
with
why
the
they
medication
switched
and
to
then
it.
we had to use clozapine, but then we decided to go with another medication. So thank you so much for that suggestion.
Yeah, no, so that, that's one of the ongoing issues. And people have to realize this is a lifelong condition. That's why I gave you the presentation briefly on psychosis. And, people need to be treated. So I think it's always better to treat with something that works better. And if managed correctly, is well tolerated and doesn't cause tardive dyskinesia. Movements, I think, are a major problem, in the long haul. And that's why 75% get it after 25 years.
I see we have another question. Susan has her hand raised. Susan, if you'd like to unmute and please ask your question.
I have a question for Robert. Is Klonopin and clozapine the same?
Now, in fact, it's very interesting that you mentioned Klonopin, because if you saw, and I went through the slides like a rocket, I know that because I was trying to I want you to have the slides because there's a lot of information there. They tried benzodiazepines, and that's what clozapine is, or Klonopin is. It's like Valium-like drug, mother's little helper. It works on GABA receptors. And that's actually, because I simplified the neurobiology, there is some interactions with the GABA system. So benzos have been tried in tardive dyskinesia. It's just, it has not worked out well. Clozapine is an antipsychotic. It's just mechanism of action is different from all the other antipsychotics. It doesn't work via blockade of D2. It has, it decreases inflammation in the brain by dampening down the microglia, which are the brain's immune cells. It has effects on what are called nicotinic receptors and GABA receptors. It works on serotonergic pathways. It's got a whole brain effect. It's a very different mechanism. And that's part of the reason people haven't used it, because they've not, they've never accepted it, because the old dogma was, if you're treating psychosis, you need to block D2. And typically you would see a movement disorder. In fact, when I was in med school and residency, we would treat the person until they got a little Parkinsonian. And then we knew we had blocked enough of the D2 receptors. Again, I'm a little older. We didn't have clozapine back then. So, so people, there wasn't a great acceptance of clozapine for that reason, because they didn't understand why it works so well. We're only figuring it out very recently.
Thank you. Sounds like, still a long way to go. I do want to be mindful of everyone's time, because I did let you know we would just be tight to an hour, and we started at 7:05. It's 8:03. So I think we have time for one more question, if anyone has one, for Dr. Laitman or for Deb Ginder. If you do, please raise your hand and unmute. Ken, looks like you have a question. Can you unmute?
Oh, no, we don't take anything from Ken. Not just kidding, Ken.
Am I unmuted?
Yes, you
Yes.
are. We can hear you, Ken.
I just want to thank Deb. Really, it takes a lot of courage to do this. I wanted to say thank you. I also wanted to mention that I've watched you now for an hour. You don't look any different than anybody else I've seen, quite frankly. Everybody has some movement going on. It's like
it's a pain though.
I know it is, but also it's my wife tells me that she has to get the veins in her legs fixed, and I tell her, I don't know what you're talking about. Your legs look fine. So oftentimes it's the problem, and I'm not minimizing it, but it's the problem is greater within than other people see. So, and I hope that you can overcome it and get out and socialize.
Thank
That's
you.
all. Thank you.
Thank you. Okay, I think we have one more. That was quick. Thanks, Ken. Sue has a question, and then that'll be our last, and then we'll have to close up shop. Sue, can you unmute and share your thought or question with us?
Yes, thank you so much for tonight. I have a 20-year-old daughter. She is not specific diagnosed, but she's treated by psychiatric medicine. Abilify, but then bipolar or schizoaffective, either one, they don't know, they can tell, but now it's more towards the bipolar, and they treat her the medicine, but then it gives akathisia really bad. So my another doctor, I switched the doctor, and then doctor said we gotta immediately stop the Abilify because that created her really bad side effect. So they stopped quite quickly. So like drop down, but then now she take the other medicine. But then meanwhile, doctor said clozapine or benzo, they prescribe her to take it. So she's taking, but then she gets a lot better after she stopped Abilify, but then she still has that akathisia, so she kind of walk around. When she gets nervous, she does more work around. She's 20 years old. Do you think is there hope for she could
So is she still on an antipsychotic?
yeah,
What is she on now?
Luxilton 1.5.
Oh, Resulti.
Luxilton. It's not
What is
like
it?
Luxilton.
Oh, Loxapine?
Luxilton. I don't know. I'm sorry the pronunciation. It's also another manufacturer. They do. Hold on one second. There is another very long name.
Yeah, let me have the long name because that I don't recognize it, to be honest with you.
Yeah, but they call Luxilton. It's a start with the X.
An X?
Luxil Ruxi.
Oh, Resulti.
Yeah,
Resulti.
Luxilti. Yeah.
Resulti. Okay. Okay. It's again, it's another antipsychotic. It's
Right.
basically E2 blockade. So, again, so unfortunately, she's someone who's a little bit more at risk for developing TD down the road, because as I mentioned, one of the things with kids, if they do develop movement disorders, acute movement disorders, that just means they have a very sensitive dopaminergic system. And those are the
Yeah.
kids that will go down. So again, and the problem is, so with the movement disorders, and especially if there's anything Parkinsonian, then they'll add an anticholinergic drug, which is great for Parkinson's, but also makes TD more of an issue. So again, unless your kid is absolutely doing fantastic, you might want to switch over to, as I mentioned already, clozapine. And you just go very slowly, and what you do is do a cross taper. And the other thing is, one of the neat little tricks with akathisias, what people don't use, are good old beta blockers. Propranolol really works pretty nicely. Is she on propranolol?
Yeah, she is.
As long as, and make sure you invest, Sue, in getting a blood pressure cuff, and that, just make sure and do her blood pressure and her pulse sitting and standing. Because, 20 years old, I don't know if she's a tiny little thing. Usually if you start low and you go slowly up with the beta blocker, you'll be okay and you won't drop their blood pressures, but you should monitor that. But consider, a low dose of clozapine. And, go to her. Unfortunately, I'm not in the position, I'm not taking, I'm not trying to do this for my own self-good. I'm not taking any new patients, but we have a lot of information on my website on how to do this. Just go to the Team Daniel Running for Recovery website. There's seminars on this. There's, the approaches are well described, but don't let your kids suffer with, it's really tough to walk around all day and feel that sense of motion.
Well, thank you, everyone. Thank you, Deb. Thank you, Dr. Laitman, for sharing everything you know and are experiencing with this. And thank you, audience, for participating and asking really good questions and being engaged. As I mentioned earlier and in the chat, this presentation has been recorded. We will be sharing that on our website as well as the slides. As always, call our helpline or check our website if we can help you in any way at any time. So thank you, everyone, and have a good night.
And thank you. And thank you, Deb. Really,
You're welcome.
really appreciate it.
Thank you.
Thank you.
All
Have a
right.
good night.
Bye-bye, guys.
Thank you.
Bye
Thank
now.
you. Have a good night.
Good night now.
Everyone.